The pediatric anesthesia is a broad terminology. We'll have to divide the children according to the age into neonates, infants, and older children. That is always better because beyond the age of 8 years, even though they come under pediatric age group, majority of the anatomical and functional changes are almost like an adult. Only below the age of 8 there are more differences between an adolescent or an adult and a child. Whereas the neonates and infants, they have much more very significant anatomical and physiological changes compared to the older children or the adolescent and adults. So we have to be much more careful when dealing with a neonate or an infant. And as all of you would be aware that when do we call a child or a baby as a neonate? What is the definition of a neonate?
1 month, sir. Within 1 month, first 7 days early neonate, 7 days to 28 days late neonate.
That's the correct definition. Jai Bharati, do you agree with that?
Yes, sir.
Yes,
sir.
You agree with his answer?
Yes, sir.
Okay, Dr. Archana Lal, are you there? Actually, the definition, supposing the baby is born at 36 weeks, will you still say that up to 40 weeks only the child is neonate? Dr. Venkateswara Rao?
Sir, post-conceptional is 60.
That is the terminology that you have to use, not just 1 month. Okay? So if the baby is born at 40, a full-term baby, then you can say 1 month is okay. But
Yes,
the
sir.
correct definition is it should be 44 weeks post-conceptional age. Up to that age.
Yes,
even if the child is born at 32 or 36 weeks, up to 44 weeks post-conceptional age, it is considered as a neonate. Then it may be 8 weeks or 12 weeks also. Okay?
Okay.
So the correct definition of a neonate is up to 44 weeks of post-conceptional age.
Post-conception.
That is the very, very important definition all of you should be very much aware of. And even in the neonate, there are two categories, premature and a full-term neonate. So how do you classify the prematurity? Is there any classification for prematurity? When do you call a baby as a premature one, and what are all the various grades of prematurity? Prematurity can be premature, mild premature, or very severely premature. It can be based on the number of weeks of gestation, or it can be based on the weight of the child. Normal less than 2,500 grams at birth is called mild. Less than 1,500 grams birth weight is considered moderate prematurity. Less than 1,000 grams per birth weight is considered extremely low birth weight. Okay, so that also will add up to the problem. So there are a lot of problems if you encounter a difference between a normal fetus born at 40 weeks of gestation and premature babies. So this also has to be discussed when we talk about pediatric regional blocks. And for that, just we have to discuss about the neurological system in a neonate, infant, and an older child. And all these things we will have to define at what age they become mature and come to a normal functional status. So as that was very well described by Rao in his description about the central neuraxial or vertebral changes that are happening, or the differences that are there between the neonate and infants, and the various implications of that was well described. There, I think Miller dogmatically says when you want to identify the epidural space, the saline injection is safer compared to the loss of resistance to air because of the soft nature of the ligaments and the tissues. So you may not appreciate the loss of resistance to air that well as you do in an adult. So they prefer always to use loss of resistance to saline rather than air. One point that is, I think, dogmatically given there, even though you included it in the controversies. Another point is, earlier they were thinking that doing a subarachnoid block in a neonate or a newborn is more risky because you can damage the cords which are very low in their anatomical position compared to the adults. So they were not willing to do that. But once they understood that the cord ends, where exactly the cord ends in the neonate, if you go lower down than that, then you can enter the subarachnoid space without causing any damage to the spinal cord. So neonatal subarachnoid block for imperforate anus or Hirschsprung disease or any laparotomies became more popular after the knowledge gained about the changes or the differences in the anatomical location of the spinal cord. But the point is, you will have to use a very correct size needle, because the longer needles that you have, which are commonly used, they cannot be used for a pediatric patient or especially a neonatal patient. So you have to have the proper equipment for that. And as he said, the CSF pressure is very low. So if you are planning for a subarachnoid block, you will not get a drip of the CSF as fast and free as you get it in an adult and an older child. So you have to be very watchful, because you can overshoot and go beyond the subarachnoid space and you may fail to locate the subarachnoid space at all. So all these problems are there in the technical management of these blocks also. And so you have to discuss about the special equipments that are needed and keeping the patient warm all the time. Even though we are doing it at the regional, the neonates and infants are more prone to hypothermia. And so keeping them warm is very important, because they quickly, especially if you do a neuraxial block, the loss of temperature will be much more faster compared to the other techniques. So children will become hypothermic much more faster. So we have to keep that also in mind and keep the ambience of the theater at a higher temperature and keep all warming devices, even though we are doing it at a and second thing is, for longer duration surgeries, however much the child may cooperate, even if they are older, it is not fair enough to keep them awake during the procedure like an adult, because suddenly they may have some fear or may become irritable or become uncooperative, and then it will be a hindrance to proceeding with the surgery. So majority of the time, even in older children, we prefer to induce anesthesia and then do the block, or if we are able to counsel the children, we do the block and then keep them sedated and continuously make them sleep throughout the procedure without keeping them awake like an adult, where we can keep them mildly sedated and make them responsive to your verbal commands. That is not practiced in pediatric cases. And with regard to the myelination and about ropivacaine, you mentioned that it is much more safer. But there is one controversy with ropivacaine. They talk about two terms, what is called Cmax and Tmax. Are you aware of that, Dr. Rao?
No, sir.
You read about that, Cmax and Tmax, concentration max and time max. What those two terminologies mean to you?
No,
See,
sir.
the time of absorption differs for various local anesthetic agents. And they say ropivacaine can get absorbed up to 2 hours from the site of injection into the systemic circulation. So supposing you do a circumcision or a herniatomy and the surgery gets over for within half an hour or 45 minutes time, we are given a block with caudal epidural. There could be absorption from the site of caudal epidural into the systemic circulation even up to 2 hours. So post-op vigilant monitoring of for LA toxicity is very, very important. And some drugs get absorbed much more faster than some other comparatively to other drugs. So we have to choose the correct drug and give the correct concentration. And the most important difference in the nervous system is the lack of myelination. So when does the myelination get completed?
12th year, sir.
12th year, yes. So, but in the growing stage, slowly the myelination improves by third year of age. Okay, so it may be totally complete by 12th year, but it is almost fully developed by 3 years of age. So until then, you will have much more sensitivity of the nervous system. That is why we are able to perform and achieve good blocks even with very, very low concentration of local anesthetic, which we have to carefully decide to choose so that we can avoid the problem of systemic local anesthetic toxicity. And another important point is about you said the heart rate sympathetic system is immature. I do agree with that. But how does the heart rate of the child is very high? The sympathetic system is not well developed. And at what age it becomes fully developed? And what is the effect of the immaturity of the sympathetic system in a pediatric patient, especially the infant? Any idea, Rao?
Sir, fully developed, sir.
No, you said sympathetic system is
Yes, sir.
not well developed.
Yes, sir.
Immature. Is that is
Yes, sir.
you
Hypotension.
mentioned that?
Yes, sir.
Then how
Hypotension is less common.
Hypotension is less common with subarachnoid block or epidural block. But my question is, if the sympathetic system is not well developed or if it is immature, how is the heart rate? What is the normal accepted heart rate for a neonate and an infant?
140 to 160. Sir.
140 to 160. So how that high heart rate is possible with the immature sympathetic system? Who can answer that question? All of us have read that the sympathetic system is immature and they have more tendency towards bradycardia. So any hypoxia produces bradycardia and cardiac arrest rather than tachycardia like an adult. If that is the normal physiological response in a neonate or an infant, how is that they have such a high heart rate?
Intrinsic SA node activities.
Pardon?
Intrinsic NSA node activities.
Exactly.
Increased.
It is the intrinsic SA activity which is responsible for that tachycardia. Okay, so it is not due to the stimulation by the catecholamines or the sympathetic stimulation which is responsible. So there is a dominance of vagal activity only. So they will, whenever there is a hypoxemia or hypotension, they will go for brady rather than tachycardia. So the compensatory catecholamine release only will not be there. So the intrinsic activity is there. That will gradually come down as the child grows and it will reach the normal age. By the time the sympathetic system will also have matured and it will start taking care of the crisis situations when the heart rate increase has to take place. Okay, that is the correct answer for that. Right. So these are all the things that you have to remember. So based on that, I just made a small PPT for you to see. So principles of regional anesthesia in children. First and foremost, we have to know the anatomical differences in the central neuraxial system. So if you, what he described as the spinal cord, where does it terminate? It terminates in the neonate at a very, very low level, L3, L4, up to 12 months of age. That is beyond that 44 weeks, it starts gradually retracts up and goes to L1, and in adult also it is between the lower border of the L1 vertebra, body of the L1 vertebra. And the dural sac, because the cord is very lowly placed, the dural sac extends up to S3, S4 in the neonate, whereas it stops at S2 in older children, and it goes to the same level in adult also. So when you do a caudal in a neonate, you have to be very, very careful, because if you take a longer needle, you will always, there is a chance that you can puncture the dural sac, and if you don't get a free flow of CSF because of the low pressure, you are likely to inject the whole drug into the subarachnoid space mistakenly, because caudal you always give a larger volume, so you are likely to inject the whole drug into the subarachnoid space and produce a very high level of block and produce even a respiratory arrest in the child. That is why they always recommend that it is better to use a Venflon, 22 gauge Venflon, to puncture the sacrococcygeal membrane. And once you get the loss of resistance or the piercing the sacrococcygeal membrane, you remove the metal needle and advance the cannula alone to inject the drug. So if you use that plastic cannula to advance into the subarachnoid space or the caudal epidural space, then you will not be puncturing the dural sac, and that will be always safer to do rather than using a metal needle for doing the caudal puncture. And the bony landmarks, the Cassius line, the intercrystal line, is also lower in children, but it is a little higher up. So when you want to do a lumbar puncture, you have to do at a very low level, at L4, below L4, L5, and not above that level, because the cord comes up to L3, L4. And the curvature of the spine, which he mentioned, they are all highly flexible, because the ligaments are all very soft, and it is always better to hold the child in a sitting position rather than doing it in the lateral position, if whatever procedure you want to do. And these scoliosis and kyphosis all develop later only in the adult. And the vertebrae, they are all not completely ossified, and they are not hard, so they are very soft, and you can damage them and inject the drug, as I said, into the bone itself, or you can carry a piece of the bone into the subarachnoid space or the epidural space, and when you inject the drug, you may deposit there, which may form something like a teratoma. It may go in and form a reaction there. So coring can happen because of the soft nature of these vertebrae. And sacral vertebrae incomplete fusion. The reason we have to give a large volume is the drug that you give does not stay in the caudal epidural space. It may seep out. So that is the reason why we have to give a little larger dose, especially if you want to do a caudal in an adult or a sacral epidural in an adult. You have to give almost 40 ml, because it can seep out through all the foramina and come out. So these are all the clinical implications that we have to do. In the neonates and infants, SAB should be performed at L4 or below. That is a very important landmark. There is a high risk of dural puncture, as I said, because of the lower termination or the attachment of the dural sac. And in all grades groups, surface marks influence the level of the needle insertion. And in adults and adolescents, a steeper needle insertion angle is required when performing an epidural compared to neonates. And infants and neonates, there is an increased cephalad spread of local anesthetic drugs due to the absence of lumbar lordosis. And they have sharp needles may traverse the bone and damage the ossification. And short bevel blunt needles should be used. And neonate and infant, there's a better ultrasound visualization of the anatomy of the spinal cord because there are no hard bones to block them. So the US ultrasound guidance is very useful in locating the level or the position of the cord and nervures and dura. And sacral hiatus has got lot of portal. So until the injection, you have to use the larger volume. Sacral epidural approaches are possible until fusion is complete. Coming to the epidural space, the fat teeth, they are all very fluidic. The epidural fat, even sometimes in adults, it is not as firm or flabby as it is in other areas. So epidural fat is always a little fluidic or a little like a more like fluid. So this is easier for the epidural catheters to go into the space several because they don't cause much of a resistance, allowing the thread of the catheter to a larger extent. And there is a leakage of the local anesthetic around the nerves also. So the nerve coverings are not firmly attached as in adults. So there will be seepage through them. That is another reason for the shorter duration, as he rightly explained. The drug will not stay there, and lack of myelin will be not able to hold the drug attached to the nerve for a long time. So that is the reason. The advantage is the onset is very fast, but the duration is shorter for the two reasons. One is it is not attached to the myelin firmly. Second thing is it is leaking and it is getting separated, and more of blood supply is there, which will also enhance the removal of the drug from the nerve site. So these are all the reasons for the lower duration of action of local anesthetic on the nervous system. So the ligament and meninges, they are all less dense. So the loss of resistance is very subtle, and you have to use better to use the saline rather than air for that, which is given confirmed in the book. And CSF volume, even though compared to the body weight, it is higher, 50%, whereas in the adult it is only 25%. And but the flow will be very much low. The pressure is low, so if you do a subarachnoid block, the flow is much slower. And in peripheral vasodilatation, hypertension are less common when you give a subarachnoid block also. So earlier they were thinking that it was very unsafe to give a subarachnoid block in neonates, but because of this advantage that it is it will not cause any hemodynamic instability. Even children who are very sick, they have performed the subarachnoid block without any complication or problem of hemodynamic instability. But the only disadvantage is the maximum duration of a subarachnoid block in a child, in a neonate, will be maximum 45 to 50 minutes. That's all the duration, even if you give bupivacaine or longer acting drugs. The peripheral nervous system, very important thing is myelination. So myelination is very immature in the neonate, but it is completed by 12 years of age. But earlier also, this is the maximum age up to which it is going on, but it completes by 3 years also, more or less. That is the time when the child starts walking and all those things. That is the reason for they are able to stand and have stability, because the myelination becomes more or less well established by 3 years of age. And LA rapidly penetrates the nerves, producing fast onset block. So LA concentration can achieve high quality dense block. Even if the low concentration, you get a block very well. So faster onset and a lower concentration is because of the lack of myelination. And the endoneurium is loose, whereas it is relatively firm. So this is allowing the greater spread of the local anesthetic. And vasculature surrounding, there is a rich vasculature in the early stages. Gradually it gets reduced, so the drug is removed faster. That is another reason for the slower timing or the duration of the block. And which drug we have to use, this should be based on the absorption, distribution, metabolism, that is pharmacokinetics, ADME. And the So the drugs which are fast absorbed, they are likely to produce a shorter duration of absorption, and all this half-life of amides are 3 to 8 times longer than the adults because their metabolism is slower, and so the toxicity also is likely to be more. So all amide local anesthetics, you have to keep a very watchful guidance on the dosage of the drug. And free fraction of LAs in infants is much more higher because of the binding is low. As he rightly said, the plasma protein levels are low. So both alpha 1 acid glycoprotein as well as albumin levels are low. So free fraction will be high. So we have to be very careful with the dosage. So enzymatic immaturity, increased TCF, low plasma proteins, all these things are the causes for increased cardiac output and increased heart rate lead to increased absorption. So sympathetic immaturity, diminished adaptability of the heart, smaller vasculature blood volume, delayed acquisition of body scheme and anxiety. All these things lead to the chances of toxic reactions much more higher. Now coming to the various dosages, ropivacaine 3 milligram per kg body weight, ropivacaine 2, levobupivacaine 3. So ropivacaine and levobupivacaine same dosage, and lidocaine of course with adrenaline, without adrenaline, chlorpropane and propane. These are the drugs which are commonly used. Coming to the second point of perception of pain, there has been some controversy earlier that because the myelination is not mature enough, children, neonates especially, don't perceive pain. That was the concept earlier. But that has been completely disproved. C fibers are fully functional from early fetal life. So they are responsible for slow or true pain, which is conveyed by the unmyelinated C fibers. So it leads to protective reflexes such as autonomic reactions, muscle contractions, and rigidity. Now, connections between C fibers and dorsal horn neurons are not mature before the second week of postnatal life. So that is why you see when you go and see a neonate, and even when you just try to tap them, they make a jerk and then reacts very fast because that reaction is the connections are not well developed. And there is a substance P receptor which is decreased during the first 2 weeks of life, and the inhibitory control is not there, which immature at birth to develop concomitantly. That is another reason why they are hyperreflexive. When analgesic agents are administered before a painful procedure, infants infants demonstrate less evidence of procedural pain and reduction in longer term changes in behavior. Inability of young patients to communicate and express their distress and discomfort is another hurdle in managing their pain. So age-related pain scales are formed to overcome this. So you can't expect a neonate or an infant to complain to you and tell you how much pain they are experiencing, but older children will be able to do. So neonatal and infant pains, we have to, that is why we have that Flack scale and other things to find out their response to pain rather than verbal communication. And coming to the pharmacology of local anesthetic and additives, two main factors influence pharmacology. One is the immaturity of enzyme pathway, and second is the progressive increase in body surface as the child grows. So, but in practice, doses are calculated based on body weight. Earlier, they were thinking that we should calculate the dosage only on body surface area, BSA. But now, because of the gradual, constant growth of the child, it is very difficult to take the BSA into calculation every time. So, the body weight basis calculation has been accepted. So LA drugs are faster onset, higher spread, shorter duration of action, especially in epidural block, because the systemic absorption and distribution are influenced by plasma protein binding, and red cell storage is also playing a role. So some of the drugs which are injected, when they reach a systemic circulation, they are stored in the RBCs also, and absorption from reticular space is faster. Hepatic extraction and clearance and metabolism is lower. Elimination half-life is prolonged, so systemic toxicity can easily occur. So what are the additives that we can use? They can be opioids, epinephrine, clonidine, ketamine, dexamethasone also is being commonly used now, and midazolam also, as because these are all preservative free, they can also be used. The physiological factors for central neuraxial blocks are virtually free of measurable hemodynamic effects up to 8 years of age. So you can give safely a subarachnoid block also in children older than the infant age of 1 year. And preloading with crystalloids or use of vasoactive drugs are rarely needed. The psychological factors are fear of new environment, stranger anxiety due to unknown faces, and needle phobia. These are all problems in older children, more than 6 months of age, or little toddlers and other people. The indications, contraindications, complications for regional are. Indications are intra and post-op analgesia. You can definitely use them. And for procedural pain like scopies, non-surgical pain, chronic palliative care, and non-analgesic indications. So contraindications are coagulopathy, active infection through allergy. If a child has got features of hydrocephalus or intracranial tumors, they should not use neuraxial blockade. And the use of certain chemotherapeutic agents, uncorrected hypovolemia, or cutaneous or subcutaneous lesions are also contraindications for regional technique. And parental refusal is an absolute non-medical contraindication. This is a very, very important factor. So you have to tell the caregiver, attenders or parents that you are planning to do a regional, and explain that to them. And if they say we don't want that, because nowadays parents also go through Google, and they may say doing a spinal may cause permanent damage to the child's nervous system and all that. So if they refuse, you have to listen to that and accept their refusal. And risk of compartmental syndrome or hemoglobinopathies like sickle cell or pre-existing neurological disorders are also relative contraindications for this. What are the complications you can produce? You can produce nerve damage by needle, tissue coring and deposition in epidural space, injection of neurotoxic solution into the nerve directly and causing permanent damage, or sometimes we can have leakage from the puncture site because the skin and the soft tissues are very, very brittle and soft. You can have if you use a very large bore needle, you can have continuous leakage of all the CSF or other fluid from that site. Systemic complication, of course, last is due to accidental IV injection or overdose, and it can be life-threatening complication. And the difference between adult and desisting is both CVS and CNS symptoms appear concomitantly. Unlike an adult, where the perioral tingling, numbness, and then the seizures, that is preceded always by the cardiovascular depression. But in children, both occur simultaneously. So that is a very important reason why it is more dangerous to have a last in child in a pediatric patient. And selection of materials and techniques for agents in pediatric. Various options are, you can do a single shot technique either with a short acting or a long acting LA drug, or you can do a single shot with a LA and an adjuvant, or you can use a catheter technique for repeated or continuous injection of LA. What are the equipments and technique? CSF hydrostatic pressure is low, so advance needle slowly when attempting spinal in infants. Loss of resistance to saline is better than air as ligaments are very soft. Peripheral nerves are very superficial, so you can do what is called surface mapping with a low current. to locate them. So, for example, if you want to do a brachial plexus block, you can use a nerve stimulator on the skin itself. And because the nerve is very, very superficial just under the skin, you can stimulate the nerve from there itself and use the needle to locate the nerve and puncture it. And small probes like jockey stick handle should be available. And USG is able to show the spinal cord clearly in neonates and infants due to poor mineralization of the bones. Acoustic devices or electrostimulation are alternate methods to identify the epidural space. And earlier techniques of this whoosh technique for caudal epidural are all now become completely obsolete. We should not use them for identifying the epidural space or caudal epidural. Selection of anesthetic solution depends on site and severity of surgery, expected duration of intense post-op pain, and daycare versus inpatient. So, longer acting local anesthetics are better chosen only for patients who are going away and getting discharged on the same day, so that they can have a little prolonged analgesia, but use a lower concentration without any motor blockade. Whereas in patients, you can go for continuous technique or adjuvant technique. And most LA blocks in pediatric patients are done for analgesia rather than as a sole anesthesia itself. And so we have to debate whether you have to do it awake or performing the block with under sedation or with ketamine or under inhalation anesthetic agent. Inhalation anesthetic agent may be used because older children may not cooperate, so they have to counsel. What are the basic safety recommendations for any type of regional technique to our medico-legal claims in pediatric patients? Thorough pre-op evaluation by physical lab and radiological and other methods deemed necessary. Select the least hazardous technique. Don't venture for exotic techniques. Detailed explanation about the merits, demerits, and complications even in emergency cases to the attenders. Possibility of block failure and alternate plans to be discussed. Obtained written and informed consent. All standard monitors recommended for the procedure to be used. Fill in the anesthesia chart with details of monitors used, vital parameters, techniques and doses used, and adverse effects if any. Treat all complications and document full details with precise timings. This is very, very important. Transfer patient to PACU and continue monitoring recovery from block, maintain post-anesthesia chart, and plan discharge when objective criteria are met with, not subjective. And if additives like morphine are added to LA drugs in epidural block, overnight admission and monitoring for delayed respiratory depression every 1 hour during the first 6 hours and every 2 hours for the next 18 hours is mandatory. Common neuraxial blocks you can give are caudal block, intervertebral epidural, spinal subarachnoid block. Upper extremity blocks commonly performed are brachial plexus, which can be above or below clavicle. Above is interscalene and classical supraclavicular. Below is infraclavicular. And lower limb blocks, lumbar plexus, femoral nerve, and fascia iliaca. Saphenous vein block, lateral cutaneous, operator, sciatic, popliteal, and metatarsal blocks. Truncal blocks, thoracic paravertebral, rectus sheath or periumbilical block, ilioinguinal or iliohypogastric, pudendal nerve, and pineal block. Head and neck nerve blocks, laryngeal nerve, stellate ganglia, supraorbital, infraorbital, or mental blocks. And local anesthetic, topical applications. Even EMLA cream comes under regional anesthesia technique. So EMLA cream is nowadays commonly used for venipuncture or taking the excision of small lesions or taking even a skin graft. For all these things, we are using EMLA or topical spray for any airway interventions. And local infiltration and field blocks are all being used for in regional technique. So these are all the points that have been given. So everything, all these things I have prepared only from Miller. So these are all available in Miller. And this is how we have, I think, can manage this question in this under these headings. Doubts or any questions?